Hello, my dear students. So, here I am, Dr. Anaya Kulkarni, your original guru for the subject of pedodontics, and I'm here again for one of its own kind of session, that is discussion of your grand test 4, an elaborate discussion of each and every question, the explanation to why a particular answer is the correct answer and why are the other answers the wrong answers, because when you get clinical questions there are chances when you are confused between two options seem similar, two options seem correct. So we here will dissect each and every option, and I am going to tell you why a particular answer is the correct answer. So let us begin with the discussion of GT4 questions of pedodontics. So the first question is, a 2-year-old patient reported to the hospital with his two central incisors intruded, having a history of fallen from the bed 12 hours ago. What should be the management plan in this patient? Okay, so what all have they asked? They have asked about a 2-year-old patient. So the first thing you need to be careful about is the age of the patient. And then he reported to the hospital with two central incisors intruded. So as soon as you've read the age of the child, you are now sure that these central incisors are primary incisors, of course. Only a 2-year-old child. So there are two primary incisors that are completely intruded, having a history of fallen from the bed 12 hours ago. So 12 hours ago, this particular injury occurred where the patient fell off the bed and two central incisors got completely intruded inside the teeth, inside the alveolar socket or the alveolus. What should be the management plan in this patient? Now we have options: surgical repositioning of the teeth and then splinting it. Okay, so what you do, you just give LA to the patient. You try to hold the teeth with the help of a forceps. You pull the teeth out, reposition the teeth where they should be, where they are supposed to be, and then you splint them there. So that is called as surgical repositioning, where you are entering into the socket, holding the tooth with the help of a forceps, pulling it out, placing it in the region where they should normally be, and then you splint it with the help of a fiber composite, fiber reinforced composite, or with the help of a ligature wire, etc. So you immobilize or splint the tooth there. That is surgical repositioning. Second option, orthodontically reposition the teeth and splint. So orthodontically, that means you place implants such that the orthodontic wire pulls the teeth out and then you splint the teeth. Option C is wait to erupt the teeth spontaneously. So option C means you do nothing. You just wait for the teeth to erupt on their own, erupt back on their own. And then option D is reduce the opposing tooth. Okay, so we have these four options. Right now, option number D says reduce the opposing tooth. There is no point in reducing the opposing tooth, because you reduce the opposing tooth when your tooth that is traumatized is touching abnormally the opposing tooth. But here there is no touching the opposing tooth. The upper teeth have gone inwards, so there is no touching of the teeth only. So reduce the opposing tooth is certainly not the right answer. Then surgically repositioning the teeth and splinting. A 2-year-old child who is traumatized so badly, you can't even imagine that child is not going to enter into your operatory. Forget letting you allow to surgically reposition. And then there is no point in surgically repositioning the teeth and splinting. Again, orthodontic repositioning, again, because of the age of the child, is not possible. Though the age of the child is so small, or the child is so young that the permanent teeth bud are still there and they are in the process of coming out, they are in the process of eruption. So in the process of eruption, the permanent teeth bud are going to push the primary teeth that have been intruded inside again. Okay, so the option here is wait for the teeth to erupt spontaneously. So just imagine a child has two central incisors intruded completely. You take a radiograph. So in the radiograph you will see permanent tooth buds, and in the permanent tooth buds you see primary tooth buds that are lodged inside. Okay, so the permanent tooth buds in the course of time are going to push the what do you say are going to definitely push the primary intruded teeth outwards, and they are going to re-erupt spontaneously. So you need to do nothing. You just have to reassure the parents. You have to give symptomatic relief for the pain that is there. You have to give ointments for any soft tissue or oral tissue injuries, and then you reassure that the teeth are going to re-erupt into their position and that nothing needs to be done. So the answer here is wait for the teeth to erupt spontaneously, right? That brings us to the next question, that is question number 2. So here they've asked, in a 5-year-old patient, so the patient is a 5-year-old patient in which a second molar is grossly carious. So we have a second molar that is grossly carious, second molar that is denoted by the letter E. So E is grossly carious. The child is 5 years old. Okay, and E is grossly. So when they say grossly carious, that means there can be no treatment done other than extraction. Always remember, grossly carious, and has to be extracted. What is the most appropriate for this patient? So the first thing, when you see that the age of the child is 5 years, the first thing that should come to your mind is that he will have a all primary dentition. Not even a single permanent teeth would have erupted. So there will be all primary teeth. So when we say all primary teeth, that means in one quadrant, what all teeth will be there? So there will be a central incisor, there will be a lateral incisor, there is going to be a canine, there is going to be a first molar, and then there is going to be a second molar. So these teeth will be present in a particular arch. So for example, this is the lower arch. Okay, so for example, this is the third quadrant. So only these many teeth are present. Okay, no other teeth are present. All these teeth are primary. Now what they are saying is that E, or the second molar, has become grossly carious. So this has become grossly carious. This is decayed, and because of this, what has happened? You have to remove it. So you are supposed to extract it. So you extracted this. Now what you are going to do? So the first option that they've given is band and loop space maintainer. So band and loop space maintainer, how does it look? For the band and loop space maintainer, you need to have one tooth over here and one tooth over here, so that on one tooth you can adapt a band, and on the other tooth you can, add a loop, or make a loop anchored there. Okay, so this is how a band and loop space maintainer is there. But the teeth are something like this. This is the central, this is the lateral, this is the canine, and this is the first molar. So where will you give the band and loop? Band and loop cannot be given here. Okay, so band and loop is out of the question. Right, there is empty space over here. Correct. So second is distal shoe appliance. Then third is no need to provide any such treatment. Absolutely not the answer, because because when the child is 5 years old and the second molar had to be extracted, that means there is a premature extraction, premature exfoliation of the molar, and hence something needs to be done, or there will be malocclusion in future. So of course no need of treatment is not the answer. And then extraction of second molar and just observation, this is similar to option number C. So option number D is also not the answer. The correct answer here is a distal shoe appliance. Okay, so how is a distal shoe appliance? distal shoe appliance looks something like this. So let me first tell you what are the indications of distal shoe appliance. So a distal shoe appliance is given when second molar is extracted prematurely. Okay, that means it is not there. There is still a lot of time for its exfoliation, but because of its gross decay, it had to be extracted prematurely. Okay, and in case when the first permanent molar has not yet erupted. In such a case, you give a distal shoe appliance. So a distal shoe appliance is given on the first primary molar and it has an extension that looks like a shoe. Hence, it is called as a distal shoe appliance that goes inside the alveolus. So that shoe-like extension is going inside the alveolus. That is why distal shoe appliance is also known as an intraalveolar appliance. Now, why do you put that shoe inside the alveolus? Because this is the first permanent molar which is still unerupted. It has not erupted, and if we do not give any such appliance, there is no tooth over here. So this first permanent molar is going to bend, tilt, and move into that empty space and come out tilted. It is going to have an ectopic eruption. It is going to be erupting outside of its designated place. So this shoe-like extension that is going inside the alveolus is actually helping the first permanent molar slide onto it so that the eruption of the first permanent molar is guided into proper place wherever it is supposed to be. This shoe-like extension does not let the first permanent molar bend into the space of the extracted tooth. So because it is guiding the eruption of the first permanent molar, the distal shoe appliance is also called as an eruption guidance appliance. Eruption guidance appliance. So we have three names here: a distal shoe because it is a shoe like structure that goes distally; it is intraalveolar appliance because it is going inside the alveolus; and then it is an eruption guidance appliance because it is guiding the eruption of the first permanent molar into proper place. So in such a case where E is extracted and 6, that is the first permanent molar, is still not erupted, such as a case of a 5-year-old child, you have to give an appliance that is distal shoe appliance. So the third question is, which of the following appliance is best for bilateral space management in the maxillary arch? So when we are talking about the maxillary arch, we can filter two options from here: either Nance palatal arch or transpalatal arch. These two appliances are used for or are used in the maxillary arch. So which amongst these two? So this first diagram here is the Nance palatal arch, and here this is the transpalatal arch. Okay, so Nance palatal arch has this acrylic button over here which is called as the Nance button. So what does the Nance button do? Nance button like holds, okay? It acts like an anchorage. Okay, it acts like an anchor over here. It holds so that the teeth do not tip forward or the space is not lost. So whenever there is a bilateral loss, that means, for example, if this tooth is lost and this tooth is also lost, you should always go for a Nance palatal arch because there is a Nance button that gives anchorage and does not let these teeth tip forward or move forward. In the transpalatal arch case, if this tooth is missing and even this tooth is missing, then what will happen? There is going to be a bilateral space here and here. this entire segment in the course of time has the ability to tip forward into the bilaterally created space, because this particular appliance does not use any anchorage. There is no anchorage. Okay, there is nothing holding on to it. Okay, so this entire unit can move a little forward into the space. So when there is one tooth so when there is one tooth that is missing, whereas one tooth is present, then what will happen? This segment cannot move forward because this particular tooth is not letting it move forward, right? Whereas in this case, even if both the teeth here are missing, this Nance button will keep holding the appliance and will not let these two molars move forward. So whenever we are talking about a bilateral space management, we always go for a Nance palatal arch and not a transpalatal arch. So the option here is A, Nance palatal arch. Now, the fourth question is, what is the most appropriate restorative treatment for a 5-year child having multiple carious lesions on multiple surfaces of molar teeth? So there is a molar tooth, and just look at this molar tooth. Okay, look at this molar tooth. There are proximal caries. You can see proximal caries. You can see a buccal pit. Then there are occlusal caries. You never know, there are caries on the lingual aspect also. Okay, so in how many places are you going to drill a cavity and place GIC? Because that when you drill cavities in so many surfaces of the tooth structure as a whole becomes very weak. So a weak tooth structure will obviously not be able to support any type of a restorative material. So the best treatment for multiple carious lesions on multiple surface of a molar tooth is stainless steel crown. See, amalgam becomes out of question because amalgam needs a proper cavity preparation, proper depth, proper rounded margins, dovetail formation, and then it needs converging cavity form and everything. So in this kind of a grossly destructed tooth, amalgam is not possible at all. Even for GIC and composite, such tooth, when you excavate caries, will become so weak, and it'll have cavities drilled in so many surfaces that it will not be able to support any type of restoration, and hence stainless steel crown is the best type of restoration for a tooth that has caries on multiple surfaces. Okay, then the fifth question is, if a child's IQ is measured 50, then what will be the category, or where will he be categorized? So for that, I want you all to learn by heart a table that is given in the book Stanford Binet, 5th edition of that book. So the classification goes something like this. So if the IQ is 140 plus, then the child is considered to be very gifted or highly advanced IQ. 130 to 140 is a child who is gifted or somebody who has an advanced IQ. Then we have children who are superior, who are considered as superior IQ children with 120 to 129 as their IQ. 110 to 119 are considered as high average IQ children. 90 to 109 are the average ones. 80 to 89 are low average IQ children. I'm sorry. Then 70 to 79 are the borderline impaired or delayed, delayed IQ, delayed mental development children. And then 55 to 69 are mildly impaired, and then 40 to 54 are the moderately impaired or delayed mental development children. So we are talking about a child whose IQ is 50, so 100% the child will be categorized as a mentally challenged or mentally retarded child, somebody who has a very low or moderately impaired IQ. So the answer here is C, that is mentally retarded. Now we come to the sixth question, that is best medium for an avulsed permanent tooth in a peripheral village school is. So, see, like you must have read that the best medium for storage of an avulsed tooth is the Hank's balance salt solution medium and everything. But when you are at a playground or when you're playing at the terrace of your home or anywhere, you do not these HBSS solution and everything you're only going to find in medical stores. But when you have a tooth avulsed, the most important time is the extra oral time. That means once it is out of your mouth, for how much time you are keeping it dry or in a storage media. So it depends how much extraoral dry time the tooth has had and how much extraoral time in the storage media the tooth has had, because the main question is the viability of the PDL fibers. Of the PDL, the viability of the PDL fibers. That is most important thing that you have to preserve. Okay, so the most common and the best extraoral media that you can find handy are milk, saline water, normal water, and saliva. These are the good storage media. Okay, now out of this, milk and saline are very, very good storage media. So when we are talking about why they have mentioned peripheral village school, so if they are mentioning peripheral village school, so in the village schools they have various programs where they distribute milk to the children there. So milk is always available at a peripheral village school because there are government schemes under which they are supposed to be distributing milk to the students of that school, and hence milk is very, very readily available at a peripheral village school. So the best media, though saliva and ice is also a good media, cold water is a good media, but milk is very readily available at a peripheral village school. So the answer is milk. Where will you go and find refrigerator in a peripheral village school? There is, you never know, you might not find ice or cold water, etc. And handkerchief is obviously not a great media for storage. It gives a lot of extra oral dry time. The viability of the PDL fibers is gone. So milk is the best answer considering they've given peripheral village school in the question. Correct? Now that brings us to the seventh question, that says Babinski's sign in children includes. Okay, so what is Babinski's sign? You would have read a lot of different signs and reflexes in case of children. So you would have read about the grasp reflex and the startled reflex and Babinski's sign and so many others, right? So what is Babinski's sign? It is basically, so out of all of these, I'm first going to tell you what it means. So if this is the foot, so when you stroke the outer part of the outer or the lateral part of the foot, the child tends to extend the toes backwards like this. है ना? Because you are stroking the outward part of the foot, the child is extending the toes backwards like this, and that is called as Babinski's sign. I will show you the picture. So the answer here is upward extension of toes when the sole of the foot is touched firmly on the outer side. Okay. So this is the upward extension of toes. What are the other options? Extension of thumb of the leg when tap or touch below or end of the fingers. No. Okay, you always have to touch on the outer aspect or the lateral border of the foot when you have to generate the Babinski's reflex or sign. The option B says flexion. So flexion means bringing together of one side of hand or leg when the head is turned to the other side. No, that is another one. And then option D is flexion of toe and hyperextension of digits. That means the toe is flexed and the digits are hyperextended. When when the clinician runs his finger on the outer side of the plantar surface of the foot of the sole. Yes, this is the Yes. Okay, towards the thumb. Okay, so the option here is C, that is upward extension of the toes when the sole of the foot is touched firmly on the outer side. Okay, so just look at the picture here. So this is how the child tends to extend the toes outwards. Okay. Now there are two things. There is one is Babinski's reflex and one is plantar reflex. So Babinski's reflex is seen in infants and plantar reflex is exactly opposite of the Babinski's reflex. Plantar reflex is also called as negative Babinski's reflex and plantar reflex is seen in a normal adult. So there is a plantar reflex that is exactly opposite of Babinski's reflex, but it is seen in a normal adult, and Babinski's reflex is seen in a child. So what is the difference? In Babinski's reflex, the toes are fanning out in response to external stimulation in Babinski's reflex. Whereas in plantar reflex, go try on your mother or father or brother or sister plantar reflex. So whenever you do the same stimulation on an adult's foot, they tend to flex the toes inwards. That is the plantar reflex. So when you grow up as an adult, your reflex is exactly opposite to that of the Babinski's reflex, and it is called as the plantar reflex. So the next question is, a child with carious deciduous mandibular teeth has sensitivity to cold and sweet food which subsides on removing the stimulus. The most appropriate treatment for this condition is. So, there is sensitivity to cold and sweet food, and when you remove it, the symptoms subside. That means 100% it is a reversible pulpitis. So, when it is a reversible pulpitis, the option D gets cancelled automatically. When it is a reversible pulpitis, you do not need to do an extraction. Then, when it is a reversible pulpitis and there is just sensitivity to cold and sweet food and no complaint of pain on food lodgement, that means you do not need to do a pulpotomy. Doing a direct pulp capping is enough, and hence the answer becomes A, that is reversible pulpitis with direct pulp capping. Okay, so this is pretty clear. If there is pain and the pain subsides on removal of stimulus, that means the coronal pulp is inflamed, and then you'll have to go for a pulpotomy. But there is just sensitivity, so that will do by just direct pulp capping. Right? That brings us to the 9th question, that is brushing technique recommended in a preschooler. So in a preschooler, 100% brushing technique that is recommended is Phone's technique. Okay, so Phone's technique is what? It is a circular motion brushing technique. Okay, so the child, you just have to show him that you hold the brush like this and go in circles all through your teeth. Just go in circles. That is called as the Phone's technique. So Phone's technique is advised in a preschooler like this. So you just go in circles like this. So that is what is recommended in the primary dentition or say a preschooler. Right? So that is Phone's technique, which is a circular motion brushing technique. Next question is, which of the following is not a feature of the normal mature swallow? So there are two types of swallows. What are the two types? There is an infantile swallow and there is a mature swallow. So when the child is in the predentate phase of life, there are no teeth in the mouth, and the child just feeds on milk by suckling or sucking milk. then that time the child has an infantile swallow. Eventually, when all the teeth erupt and the child is weaned off of the milk and he starts eating solid or semi-solid food, then the infantile swallow gets converted into the mature swallow. Now, what are the features of mature swallow? So usually by 18 months of age, the following mature swallow characteristics are to be observed. So what are the characteristics of a mature swallow? The teeth are together. So whenever you swallow, so you try and swallow your, try yourself and see, when you swallow, the teeth come together in contact. Okay, the mandible is stabilized by contraction of the mandibular elevators, these being primarily innervated by the trigeminal nerve. So trigeminal nerve innervates the mandibular elevators, and the mandibular elevators contract to stabilize the mandible when you swallow. The tongue tip is held against the palate above and behind the incisors. So when you swallow, your tip of the tongue is placed on the palate just behind the incisors. Okay, against the palate and above behind the incisors. There are minimal contractions of the lips during a mature swallow. So the lips have minimal contractions during a mature swallow. Now, what are the options they give us? So, let's begin with the option number D. So, tongue touches the anterior part of the, so they've asked which is not a feature. So, which is a false statement they've asked, okay? So, tongue touches the anterior part of the palate behind the maxillary anterior teeth. So, yes, this is a true statement. C is there is no momentary contact of the teeth during swallowing. Okay, so there is no momentary contact of the teeth during swallowing. This is the false statement. B says there is slight contraction of the perioral muscles. So yes, there is minimal contraction of the lip muscles we just read. So slight contraction. And there is no abnormal forward tongue thrusting. That's again a true statement. So the answer here is C. This is not a feature of mature swallow, a normal mature swallow. Rest three are the normal mature swallow features. Correct? Okay, so I think there is, yeah, okay. So in a complicated fracture that involved enamel, dentine and pulp as well in 5-2. So when they say 5-2, so what does tooth number 5-2 represent? Tooth number 5-2 represents a primary right lateral incisor. Okay, so primary right lateral incisor is 5-2. So in a complicated fracture involving enamel, dentine and pulp in tooth number 5-2, which type of Ellis classification it will be? So when you see such type of a question, you immediately jump on class 3, because class 3 Ellis fracture means where there is involvement of enamel, dentine and pulp. But just read the question twice. They've asked you, they've given you a tooth number 5-2, which means a primary tooth, and any sort of a fracture in a primary tooth is class 9. So the answer here is not A but D, that is class 9, because they've given you a primary tooth in question. Any type of fracture in a primary tooth is class 9. So this is the Ellis fracture classification. 1 means where enamel is involved, 2 means where enamel and dentine is involved, 3 is where enamel plus dentine plus pulp is involved, 4 is when it becomes non-vital with or without loss of crown structure. Class 5 is tooth lost or avulsion. Then class 6 is fracture of the root with or without loss of crown structure. Class 7 means displacement of the tooth without fracture of the crown or the root. Class 8 means fracture of the crown en masse. So fracture of the crown en masse. and class 9 means any injury to the primary dentition. So the answer here is class 9 and not class 3. So be careful when you read the questions. Now, 2% sodium fluoride application is done on a tooth root with extraoral time of avulse tooth more than 60 minutes. So, what is the reason of applying 2% sodium fluoride to the avulse tooth? Why do you apply 2% sodium fluoride? So, basically, fluoride is applied to the tooth, to the root surface of an avulse tooth to reduce root resorption and to ensure optimal healing. So, this is according to the guidelines of the IADT, that is International Association of Dental Traumatology. It recommends treating the root surface with 2.4% sodium fluoride for 5 minutes. Other protocols may involve soaking the tooth in a solution of 2% sodium fluoride for 20 minutes. So, basically, the answer here becomes to prevent external resorption and delay the ankylosis, promote healing. So 2% sodium fluoride in an avulse tooth actually prevents the external resorption. That brings us to the 13th question. So it's an easy question. Till what age a newborn is called a neonate? So basically, a neonate is any child that is under 28 days of age. So 28 days, that means 4 weeks or 1 month. So a 1 month old child, any child who is 1 month or below is called as a neonate. So that is option number B. That brings us to the last question of the GT4, that is, which is not true during transition from deciduous to permanent teeth? Okay, which is not true. So we are supposed to find out the false statement. So statement A says, reduce arch circumference due to use of leeway space by the molar. So yes, this is a true statement. The leeway space is used up by the molar movement and the arch circumference reduces. The increase in our interarch canine width, this is also a true statement. Slight labial placing of the lower anteriors. So no, the lower anteriors are placed lingually. So this is the false statement. And then D is mesial drifting of the premolar after primary canine exfoliation. So yes, it uses up the leeway space. So this is the true statement. So the answer here becomes C, that is slight labial placement of the lower anteriors, because the lower anteriors are placed lingually as compared to the primary anteriors. I hope you've understood every explanation to every question. Go through it, read your subject well, and if there are any doubts related to my subject, please post the doubts on the group and I will be there to solve your doubts. Thank you so much.